Hello, everybody. Thank you for listening to this talk about MASLD and MASH for the Community Network. My name is Erin Tanner. I'm a nurse practitioner at Gastro Health in Birmingham, Alabama. I have 14 years of experience working in community GI, which includes some hepatology and inflammatory bowel disease. Here's the QR code to record your attendance today. And we're going to be talking about comparing F3 and F4 fibrosis and how we should manage these patients. We're going to have two case studies. We're going to have Sam A and Sam B. We'll start with Sam A today. He's a 55-year-old male. He's been referred to the GI clinic for mildly abnormal transaminases. He has had an abdominal ultrasound that shows increased liver echogenicity, and he complains of fatigue. As you can see to the left here, his BMI is 33. Here's some information about Sam A. His past medical history includes type 2 diabetes, hypertension, hyperlipidemia, sleep apnea, and he does not use alcohol. You see a list of his medications over here to the right. He has some high blood pressure medicines, medication for high cholesterol, and he's on Farxiga for his type 2 diabetes. On physical exam, he has an obese abdomen. He has no stigmata of chronic liver disease, and there is no hepatosplenomegaly. As far as Sam A's lab values here, you have his vital signs over to the far left. Again, his BMI is 33. As far as his lab goes, he has elevated transaminases with normal alk phos and normal total bili. His platelets are normal. His hemoglobin A1C is elevated at 7.1. Over to the far right here, he does have an elevated ferritin at 780 with a normal iron percent sat. He does have a positive ANA with a low ratio of 1 to 80. Anti-smooth muscle antibody and hepatitis B and C are all negative. When thinking about doing non-invasive tests on this patient, there are several options, starting out with a FIB-4 score, which includes calculating or putting into a calculator a patient's age, their transaminases, as well as their platelet levels. You come up with your FIB-4 score. And for Sam A, his is 2.7, which is consistent with intermediate risk of having hepatic fibrosis. So if you do a FIB-4 score and it does come up intermediate, certainly ordering other non-invasive tests would be beneficial here. So Sam A went on to have a FibroScan, and his KPA level was 11 and his CAP score was 262. So the KPA level measures liver stiffness, and then the CAP score measures the level of fat in the liver. And as you can see here, his KPA score is 11, consistent with significant fibrosis, and this CAP score is 262, which is consistent with moderate steatosis. He also had an ELF blood test done. This is a proprietary test offered by different laboratories. His ELF score was 9.9, which again, as you can see to the right there, is consistent with severe potential fibrosis, but not cirrhosis. So for patient Sam A, the question is, are there any further testing you'd like to perform on this patient, and how would you stage this patient? So for Sam A, with his ferritin being 780, I would consider checking a hemochromatosis gene test. There are other proprietary measures you can use, like the FibroSure, when you're not sure what stage you want to consider your patient. And then also another NIT, the MRI-PDFF, if you have access to that, is also a good measure of hepatic fibrosis. How would you treat this patient, and what would you monitor with him? I would consider him having F3 fibrosis, not cirrhosis. So you may consider starting these patients on Rezdiffra, certainly educating them about lifestyle modifications, avoiding all alcohol. With my fatty liver patients, I typically recommend no alcohol and hope they avoid all alcohol, because if you give them some sort of limit, in my experience, they tend to go over. Certainly keeping good control of his high cholesterol and a good control of his weight are certain things to consider. Using a GLP-1 medication would also be something to think about in our patients that are overweight and have F3 fibrosis. And then there is a lot of discussion about, should you monitor your F3 fibrotic patients for hepatocellular carcinoma? And with that, I think you just have to take it case by case basis. You may want to consider other risk factors they may have, such as have they had a long history of excessive alcohol use? Are they obese? Is there a family history of HCC? Patients that are male at increased age are going to be higher risk for HCC. So when you have F3 fibrotic patients, look at other risk factors and then determine, should you check an AFP and an abdominal ultrasound every 6 months? And certainly it is appropriate to do that, even though they're not cirrhotic. So now let's look at SAM-B. Same patient profile here. He's 55, same past medical history, same medications, same physical exam, but these are SAM-B's lab values. Again, elevated transaminases with normal alk phos. SAM-B's total bili is a little bit higher than SAM-A, and also he has low platelets at 128,000. Over to the right here, still elevated ferritin with normal iron percent sat. Same patient, but different non-invasive test scores. So he had a FIB-4 score that was considered high risk. And then SAM-B went on to have his FibroScan that showed a KPA level of 21, which was significant for advanced fibrosis, and then a CAP score of 245, which was moderate steatosis. He also had an ELF blood test done that was 11.4, which was considered a very, very high risk of hepatic fibrosis and cirrhosis. So as far as other testing to consider for SAM-B, certainly, again, checking hemochromatosis gene test would be fine. If you're unsure about your patient having cirrhosis or not having cirrhosis, doing a liver biopsy is still acceptable. We have all these non-invasive tests, which are very beneficial, but if you have the NITs that come back indeterminate or are not consistent with each other, then a liver biopsy is perfectly acceptable. And for SAM-B, I would say that he has cirrhosis, given he has his NIT scores that are very high risk, as well as his low platelets. How would we treat this patient, and what would you monitor? Certainly diet and lifestyle modifications, just like SAM-A, avoiding all alcohol, keeping good control of your comorbidities, diabetes, high cholesterol, keeping good control of your weight. Certainly with our patients with F4 fibrosis or cirrhosis, you want to monitor them every 6 months for hepatocellular carcinoma with an AFP and abdominal ultrasound. And then we do need to do an upper endoscopy to screen for esophageal varices. So as you can see here, these are the differences in the NIT values for SAM-A on the left, SAM-B on the right. SAM-A was considered to have F3 fibrosis, SAM-B cirrhosis or F4 fibrosis. Values are different here. So as our final discussion, these two patients do compare in a lot of their, as the way they present. We have patients that come in with abnormal liver enzymes. They both had the same comorbidities. They both had the same physical exam. But then once you did your non-invasive testing, they did turn out to have two different diagnoses. One had F3 fibrosis, one had F4 fibrosis or cirrhosis. And the way we treated them was a little bit different. Again, if you have indeterminate non-invasive tests, always consider liver biopsy. That's still a perfectly acceptable option to try to determine what stage of fibrosis our patients have. And as far as HCC surveillance, look at the risk factors in your patients with F3 fibrosis to determine if they need to be screened every 6 months. And then, of course, for our cirrhotics or F4 fibrotics, screening them for HCC every 6 months needs to be on your list. You can visit our GAP, MASLD and MASH Community Network to look at other disease state educations, as well as learn about Rezdiffra and other fatty liver information. Does anybody have questions?
If anyone has any questions, feel free to unmute yourself, or you can add the question to the chat box.
Hey, I had a question. So
Yeah.
I think you said about Hep Quant. Is that right? That you may order that test, or maybe I
Which
missed.
one? I'm sorry. What'd you say?
That you I thought you said something about Hep Quant that you may order that test.
Oh, so was it hemochromatosis?
Oh, hemochromatosis. You said that. Okay, I was
Yeah,
thinking of something different. Okay, all right. So
yeah.
what were you ordering that test for?
So his ferritin was elevated at 780.
Oh, okay, I got
Um,
you. Okay,
yeah, so always, consider ruling out hemochromatosis as a source for elevated transaminases when their ferritin is high like that.
okay. Thank you.
Yeah.
I had one more question.
For sure.
So, there's different perspectives when you listen to different speakers about FIB4, and in fact, some of them say, of course, age is produces a negative value sometimes as a negative positive predictive value, as well as AST low and platelets low. But they even say that diabetic patients oftentimes will show up with a low FIB4, and then you may miss patients who have significant fibrosis, especially those with obesity, metabolic syndrome. So, how do you handle those? Do you routinely just go ahead and FibroScan diabetic, or MRE, or whatever that you prefer, NIT you prefer, ELF, or do you rely on the FIB4 in your clinic?
So certainly we do calculate FIB4 if we have a patient that comes in for, a non liver related issue, and they do have other comorbid issues, diabetes, obesity. We will calculate a FIB4, and then if it is higher risk, we would order another NIT. If the patient had other comorbid issues and were not in my clinic for a liver related issue, we probably would not. Now, I think that what I see in community GI that is shifting is patients that come in for a non-liver related issue, such as epigastric pain, and we ordered an abdominal ultrasound and it incidentally shows fatty liver. And that's kind of the shift in our workup that I'm seeing, is that when you have that, now we really need to order another NIT, even though they weren't there for a liver related issue, doing a FibroScan, an elastography, checking an ELF. We can't just ignore that, or we can't just continue to say, follow a low fat diet and avoid alcohol. I think there's some other testing that you should do if you have a patient like that in your clinic. Does that answer your question?
Yes, that answered me, because when you look at the studies, NASH, Master NASH, Synergy NASH, Essence, like all the FIB4s are, 1.3, 1.6. So there's possibility that some of those lower range patients that were in those trials were even 1.0, that you may miss those if you're only you're only looking at a Fib4. So I appreciate that
Yeah.
explanation. Thank you.
Yeah, absolutely. And I think, in my opinion, the Fib4 is going to be most beneficial in primary care offices in getting the high risk patients over to GI or hepatology. But it's a useful tool. But like you said, there are going to be patients that are missed if they're of the higher age or even lower age. Their Fib4 is going to be skewed. So, I don't know if you do strictly hepatology or general GI, or primary care, but I think Fit4 would be very beneficial in primary care and capturing some of these patients. And then, in the GI clinic, if they're not there for a liver-related issue, that's going to be helpful in capturing those patients.
Another question in the chat box as well.
Okay. Let's see. Ferritin can be elevated as a transient mark of inflammation. No, the iron percent SAT was elevated, and certainly ferritin can be high with inflammation. But, when you're considering putting a patient on a medication like Rezdiffra, then you want to rule out other liver-related issues prior to starting a medication like that. Have been told to stop ordering FibroSure. That is not an accurate test. Oh, it's okay, Jennifer. So I don't use FibroSure routinely. I typically in our clinic we have elastography, and then I certainly use ELF a lot because it has been shown to be more accurate than things like FibroSure. But sometimes I will have those tests come back indeterminate, or they don't line up. So their ELF may be high risk, but their elastography shows low risk. So, and those are the types of situations where I would consider doing a FibroSure, or even going straight to liver biopsy if you're not sure. But I do not routinely order FibroSure. It is offered, we have LabCorp in our office, but I usually do ELF over FibroSure because there have been studies that show it's more accurate. Thank you, Jennifer.
Great. Well, Erin, thank you so much. That was an excellent presentation. We really appreciate it. And thank you everyone for joining us today. We look forward to seeing you at another regional meeting within the MASLD Community Network. And we will be sending a notification out when Erin has new content posted on her community network page, as well as this recorded presentation. So thanks again and have a great day, everyone.
Thank you.